Hello, my name is Kevin Letts. I am a nurse practitioner who practices in the area of allergy, asthma, and immunology since 1999. So I've done this a while, both in private practice and in more of an academic setting. And one of the things I believe that I miss frequently in private practice, and probably just more related to the time frame, was eosinophilic esophagitis, commonly known as EoE. I think we thought we were quite smart in identifying GERD, or gastroesophageal reflux disease, in young patients with asthma. But it wasn't until a pediatric gastroenterologist came into town and started biopsying some of these children where we found EoE much more common. So that's what we'll be talking about today, and looking forward to learning with you. So this here is an eosinophil, quite pretty. You can see the purple nucleus, which is bilobed, and the cytoplasm, which is stained pink here with granules in it. There are over 200 granules, and of course these are what are released when the eosinophil is activated, and these granules can be toxic both to invaders, but then also, of course, our own cells and tissues. The eosinophil gets its name because of the H&E stain that is performed, and it's eos loving, which is the pink stain here. We probably most likely see eosinophils when we're looking at blood counts, and but in reality, eosinophils are more tissue-dwelling cells, several hundredfold more abundant in tissues than in blood. What's important to note is the degree of peripheral blood eosinophilia does not always accurately predict the risk of organ damage or damage to tissue. When we see eosinophilia in the blood, we think of worms, wheezes, and weird diseases. Worms being parasitic infections, more commonly seen in other countries, less westernized, but we do see it travel on occasions. Wheezes, meaning allergic disease, which is quite common to see. Usually this will just be a modest increase of eosinophils. And then weird diseases, which classifies a lot of malignant diseases as well as other less common conditions. But today we're talking more about eosinophilic esophagitis. The eosinophil should not be commonly found in the esophagus, and very little in the entire GI tract for that matter. The eosinophil is a pro-inflammatory white blood cell, and as you can see here, quite a few granules, and at one extreme, the eosinophil can help with illnesses such as erythema toxicum, and in other cases they can be detrimental, such as in hypereosinophilic syndrome or other conditions, and particularly just in the tissue when they become activated. The eosinophil, again, should not be in the esophagus, so when it is in a great number, it can cause significant problems with hyperplasia, which then leads to the various symptomatology. It is thought to be provoked by food or aeroallergen exposure, high propensity of allergic disease in people with EoE. And it tends to be refractory to PPI treatment, proton pump inhibitors, or really even any acid suppression. However, there is some concomitant illness at times, so you will find people with EoE who also have GERD who are on PPI treatment or some sort of acid suppression therapy. So here we have some endoscopy pictures, which in the first case of A reflects a fairly normal vascular pattern, but in the distal esophagus we see some obstruction. The B here we see this, this white exudate coating the mucosa, which is not uncommon to see in EoE. And the last picture here, C, shows actually some shearing that occurred after balloon dilation. In many cases, there, particularly in the adults, we have some strictures and the esophagus needs dilation. You have to be careful about this shearing effect. Of course, with this inflammation and such, we have the complications such as scar tissue in the esophagus and strictures, as well as food impaction and dysmotility of the esophagus as well. So this occurs in what we think about 1 to 4 of 1,000 children and about 1 out of every 2,500 adults. There is a greater propensity for males than females, and we see the incidence rising, even more so than we think, just because of the increased diagnostic capabilities, but we see it paralleling the rise in allergic disease. We don't see any identified difference in geography, location, race, or socioeconomic distribution or seasonal variation either. As mentioned, it's commonly associated with allergic disorders, whereas 75% of EoE patients suffer from some sort of allergic disease such as atopic dermatitis, asthma, allergic rhinitis, or IgE-mediated food allergies. The symptoms, and most commonly in children, what we see is some sort of feeding problem, either with regurgitation or emesis, and even some failure to thrive. Occasionally we'll see some dysphagia and food impaction and heartburn as well. In the adult population, certainly you want to be thinking about EoE in anybody who presents with food impaction, particularly more than once. But then otherwise you see sort of common reflux symptoms, dysphagia, chest pain, and abdominal pain. Occasionally we'll have some diarrhea and weight loss as well as vomiting, but less so with the vomiting in the adult population. So where do we begin with our evaluation? Typically the gastroenterologist will start with the CBC, electrolytes, amylase, lipase, a SED rate, as well as UA and upper GI, really to look at your differential diagnosis primarily. We see that eosinophilia is present at times, but less than 50%. pH probe monitoring, approximately 38% may have coexisting disease, but then of course we have the other population where this is going to read normal. On endoscopy findings, oftentimes it's visibly normal, but then we also will quite possibly see some linear furrowing, some white plaques that we saw, circular rings, transient or fixed, or what we call flanellization, and then, as mentioned again earlier, the linear shearing or crepe paper mucosa, particularly with the passage of a dilator. And we will see sometimes stricture, both proximal, middle, or distal. But the real key here in the diagnostic point is that a biopsy will show greater than 15 eosinophils per high power field. So this is diagnosis right here of EoE, is this greater than 15 eosinophils. So let's go through a quick case study. Here we have Mickey Mouse, who is a 5-year-old male who presents to his primary care provider for the 3rd time in the past 3 months for recurrent vomiting. He has a history of reflux, treated on and off with acid suppression since infancy, but more recently here we've had occasional bouts of emesis that have become more frequent, occurring daily with no clear pattern or food association. Mom has also noticed that his intake has dramatically decreased with notable weight loss. He has a history of mild intermittent asthma and multiple aeroallergens, and he was started on omeprazole at the first visit, which is not taking care of his symptoms. The only physical finding here we really see is a little bit of atopic dermatitis and his drop in his percentile in weight. Initial diagnosis, recurrent emesis of unknown etiology. On the initial workup, we find elevated eosinophils. The amylase and lipase are normal, UA normal, SED rate is normal, upper GI is unremarkable. Head MRI to look for intracranial pressure increases or mass is normal. On specific IgE testing in the blood, we find a milk class 4 and an elevated total IgE. And then on upper endoscopy, we see some linear furrowing that we talked about, and the biopsies revealed greater than 40 eosinophils per high power field. So this patient has EoE. So just to sum things up, you should really consider EoE in young patients with GERD-like symptoms, particularly feeding problems and vomiting. And with those adult patients, particularly GERD that is not coming under control, and particularly in food impaction. So we have patients going to the ER on multiple occasions for the food impaction. So here are a few resources to do additional research if you're interested, and that wraps things up. And if you're interested in asking questions, feel free to reach out to me either via Doximity or LinkedIn or other social media as well. And thank you very much.